Good morning and welcome. My name is Celia Kane. I'm the risk manager for Our Lady of Lourdes Hospital, and this is a basic orientation to risk management. So what is risk management? And that's generally the question I would ask you if I was standing in front of you. Try to get some ideas from you folks about what does a risk manager do, what is the purpose of risk management. A basic definition that I use is that it's activities undertaken to identify, evaluate, and reduce the risk of harm to patients, staff, visitors, and the organization as a whole. Basic role of a risk manager is to protect the assets of the organization. What are the assets of the organization? I have patients here, but I really think staff is probably the number one asset. I'm of the notion that if staff employees aren't happy, then the patients aren't going to be happy, and the physicians aren't going to be happy, and the locums, as you folks, are not going to be happy. So patients, staff, physicians, PAs, nurse practitioners, property, reputation, resources are all obviously very important assets of the organization that we wouldn't be able to keep our doors open without. What do I do as a risk manager? I oversee the provision of insurance. Now, that doesn't come directly from us. We're part of Ascension Health, which is our corporate entity, and they are what's called a self-insured retention. So they provide the first level of med-mal liability insurance to our providers. They also provide the first level of, provide general liability as well. They purchase property, auto, D&O, which is directors and officers, workers' comp, that kind of insurance as well. We work with our Chief Compliance Officer, Director of Compliance, to make sure that we stay compliant with regard to the many various and sundry regulatory obligations that we have to both state and federal governments. We manage legal claims, a big part of what I do in terms of claim investigation, disclosure, investigate adverse events, which often lead to legal claims, unfortunately, and assist with disclosure. And we will talk about the core process, which is communicate openly, resolve early, towards the end of this presentation. It's a initiative that has come down from Ascension Health, and again, we'll talk about that in a little bit. So what are adverse events? I'm sure many of you, if you've been in the business for a while, have either been involved or know of unfortunate outcomes, adverse events that have occurred. Why do they occur? Lack of communication is really a big reason why things occur. We'll talk about that in detail. Delays in treatment. Think about the numerous events that can occur from delays in treatments. You know, somebody has a chest x-ray, it shows a lesion, we don't follow up on it in a timely fashion, they go for another procedure, and a couple of years down the line, and they see that the initial x-ray had a lesion on it. Delay in treatment. Or something is as straightforward as there's a pregnant woman having, in the midst of having a child, they have late decelerations, and we don't get a physician in to evaluate that in a timely manner and don't implement a C-section in a timely manner, and there's an adverse outcome. Medication errors, patient falls, post-op complications, the big ones: wrong-sided surgery, maternal death and injury, hyperbilirubinemia, rape under care. Those are all Joint Commission sentinel events that require that we do root cause analyses, and some of them are likewise reportable to New York State. So adverse events are and sundry, unfortunately. As a risk manager, and you may find that different people approach this differently, but I look at two things. And we look at two things. Was the standard of care met, and was there harm to the patient? If the answer to the standard of care was met, yes, and there was no harm, then even though you may end up having an unanticipated outcome, the likelihood of winning a legal suit is slim to none. If the standard was not met, then we have an issue, obviously, and if there was harm to the patient, and depending on whether that harm was permanent or temporary, then we have a bigger issue. We look at negligence, and negligence is defined as the failure to use such care as a reasonably prudent person would use under similar circumstances. So what that means with regard to your practice is that you're here working at a community hospital in upstate New York, about 150 beds with limited specialty services. We're not going to compare the care that you would deliver to the care that would be delivered, say, at Johns Hopkins or Georgetown or Hospital, University of Pennsylvania. We're looking at the care that would be delivered at a similar size facility with similar services under similar circumstances. So I alluded to the fact that poor communication is a precursor to adverse events, and we see trends in adverse events, communication being the number one. We also see trends with documentation, critical thinking, chain of command, coordination of care. That's a big one. I briefly talked about a patient who had a lesion. We had an event in our distant past where a patient came in, had been seen in the emergency department, had a chest x-ray which showed a lung lesion. The patient was to follow up in the outpatient setting. They did, but the provider didn't address the lesion, came back to the hospital 4 years later for a unrelated procedure, and the surgeon at that time said, "Oh, you have this lesion, and what do you know? Was there 4 years prior." So coordination of care is a big one. Credentialing, we look at when you're coming to practice here, obviously you need to have privileges and credentials, and are you credentialed to do the procedures that you're doing? And we don't run into that too often, but on occasion, things like laser eye. If we've got people who are credentialed for certain wavelengths of laser, and then they use another wavelength, that's something that we want to be aware of. Unprofessional behavior is another unfortunate trend we see. So let's take a moment and talk about communication. It is, and I usually ask this question of folks before I put this slide up, but it is the number one reason why patients and families sue. Poor communication. I've been involved in unfortunate events, unanticipated outcomes where there was straightforward negligence, it was just a mistake, let's put it that way. The pieces of a hip implant, for example, mismatched sizes on the hip and the ball joint implant, had to repeat the surgery. The patient was not happy about having a second surgery, but the physician communicated with that individual so straightforwardly, so transparently, that the individual is having a second surgery with that same provider. So communication is key to preventing lawsuits and keeping people informed. When can communication breakdown occur? And I bring this up because these are the times that we see most frequently. Change of shift, nurse to nurse, physician to physician, at discharge, consults, ED hospital stay to outpatient follow-up visit, which I alluded to earlier. Also, think about it. If you're seeing you're seeing a patient, you're standing in the door, you're standing in the door with your hands folded, one leg in the door, you're in one leg out, you're sort of turned to leave, and then you ask them sort of in a curt tone, "Hey, do you have anything else you want me to do for you before I leave?" People are going to very readily perceive that. 60% or 70% of our communication is nonverbal. So taking the time to recognize the tone of your voice, what your nonverbal body language is saying, is important as well. All common sense stuff. What are some opportunities for communication? Patient care conferences. I say this to our nursing orientation, to our physician orientation, to medical students. When in doubt, request social work, case management, pull together the team so that the patient and the family understand what's going on with them. If you clarify the plan of care for them, it will build trust, set realistic expectations. It resolves any disconnect. It includes, ideally, you get a weigh-in by the treating disciplines, which could be as varied as internal medicine, the hospitalist group, endocrinology, cardiology, nephrology, pulmonology, you name it. I mean, there can be podiatry, there can be a number of disciplines treating a patient, and no one is on the same page, or no one has communicated, and the documentation is sparse, and so nobody understands what the true plan of care is. It also involves patients and family in the decision making, which is key to keeping folks. It obviously takes time. There's no doubt about it, and I know we're all rushed in this level of medicine we practice to perform better under quicker, leaner circumstances, but fixing problems later takes so much more time. It's incredible. And it just creates stress on both the providers and the patients that's unnecessary. We also look at trends in documentation. When I talked briefly about, change of shift reports and trying to figure out what happened prior. So I'm a nurse by training, and I used to work at an organization where they taped change of shift report. I don't know if any of you have ever experienced something like that, but it doesn't give you any opportunity to ask questions. You get the information that the person at the end of their shift decided was germane, and it may not be enough. So it was not a very effective way for the oncoming shift to know what happened prior, in particular if the documentation was poor, because there was just no story. So documentation should be, and I'm not telling you anything you don't know, accurate, objective, complete, facilitating communication of the essential facts, appropriate and professional, which is essentially the same as accurate and objective, and legally credible and medically useful. So, to use descriptive adjectives about a patient's attitude or a colleague's attitude doesn't really help, is not medically useful, and also is not credible. It actually can be hurtful down the line. So why do we dwell on documentation? Because the legal summons often arrives 1 to 2 years after the incident. We had a summons that we received September 11th, and the statute of limitations for wrongful death in New York State is 2 years, and the patient died September 18th, 2011. So that was 7 days before the statute was ready to expire. We received the summons. From there, you get, the summons needs to be answered quickly by an attorney, 20-25 points generally, just some basic answers. But then we start interviewing staff, and then depositions occur, and it can be, 3.5 years before there's really any meaningful activity on the event, or on the case, and the record may well be your only memory of the event. So if it's not documented, it's not done, which is an old adage. And the other thing I like to ask is, think about it. How many people know what you had for dinner a week ago today? If it's not, unless you come across an event that is memorable, or for example, a meal, you went to, I don't know, Morton Steakhouse and had a memorable meal sometime, you're not going to remember it unless it's in the documentation. And if the documentation is poor, you're not having any memory of it. Other issues that we look at with regard to risk and to adverse events is understanding your scope of practice. I worked with a nurse down in North Carolina who was very adept at starting arterial lines. We worked with a pile of residents, and the residents had shown this nurse how to do this work. And unfortunately, it was outside of his scope of practice. It was not something that an RN should be doing in any setting, inserting an arterial line, maybe, unless they're working as a paramedic or a flight nurse. Use your chain of command. There's a case down in Delaware where a nurse didn't feel comfortable with the physician's discharge of a patient, but didn't go up her chain of command, and the case was sued. It was an 18-year-old who had an ATV accident, almost lost his leg. Long story short, the case was sued, and the physician settled, and the hospital was sued, and the nature of the suit was about chain of command. So if you're uncomfortable with something in your setting, and as a physician, feel free to go to your to the chair of the department or up to the VPMA. We certainly feel that that's appropriate. Understand your credentialing obligations. Probably more important for you folks as locums than most, in that you're here a short time, and you should really understand what it is you're credentialed for and what your privileges are. Know the hospital policies, and that's not an easy task because there's hundreds of them, but at least where to find them. There's a icon on the intranet, or a link on the intranet called Compliance 360, and all our policies are housed in there. And feel free to use risk management as a resource. I get a lot of calls about consents and capacity, and can certain family members make decisions, and can certain family members have access to medical records, privacy issues. So feel free to reach out to me. My number will be on the end of this slide presentation as well. So let's talk briefly about CORE. CORE is Ascension Health's philosophy of resolution of adverse events. It stands for Communicate Openly, Resolve Early. What it does is encourage empathy, open communication between both patients and providers. Staff can be used in basic communication. It doesn't necessarily have to be an adverse medical event that occurs. But if an adverse does occur, there's a team, there's 4 of us, who will ask you to come together with us. We'll talk about how do we discuss it? How do we apologize if appropriate? How do we anticipate what questions might be asked? If we don't have all the information, as clinicians, we're kind of adept at trying to provide in detail clinical explanations to folks that very often they don't want that. There's an abbreviation AID, which is acknowledge, investigate, disclose. So essentially, we would help you initially with the acknowledgement. I know, for example, this event has occurred. You didn't expect it. I didn't expect it. Give us an opportunity to see if we can figure out why it happened, and then we will, get back to you. You certainly can apologize for the event. I'm sorry this happened to you. But it would make it what we call a blameless apology. And we will help you through that. The patients do want to hear from their physician or provider versus hearing from a risk manager. So we do guide the providers through this process. And then if the patient needs any follow-up, we would handle that and guide you through that as well. So the core team consists of my boss, Ann Wolanski. She's the Vice President of Risk Management. Deb Mikan, who is our VP of Nursing. Myself, who is the Risk Manager. And Kelly Goff, who is our Patient Advocate. We've all been through some 2-day training up in Albany that really was key in helping to understand how these disclosures can be made without there being too much angst. Disclosure is not an easy process for anyone, and we don't want you to feel like we're placing blame or throwing people under the bus, but it's about being transparent with events that occur to patients because they're entitled to that. Those are my phone numbers on there. 5157 is my office. The other number's my cell. Feel free. You're certainly welcome to reach out to me. And with that, I say welcome to Lourdes. We're glad to have you here. Maybe you'll like it enough to stay on full time. If not, we're glad to have you providing care to our patients. Thanks.